Well, thank you, and looking forward to this exciting session. So I'm going to update you on the latest ACC practice guidelines on HCM. These are my disclosures. So I'm going to focus on the recent updates to the guidelines that were made in 2024. The previous were in 2020. Talk about the key takeaways. I'll focus on cardiac myosin inhibitors. That's a major update since 2020, as well as changes to the recommendations in regarding exercise. I'll make a comparison between the U.S. and ESC guidelines regarding assessment of patients for sudden cardiac death. So these are the top 10 takeaways from the guidelines. Number one, that shared decision-making is essential in taking care of patients with hypertrophic cardiomyopathy, making sure that you spend time talking with the patient about making decisions. That patients should be referred to centers that are excellent in taking care of these patients, that see a lot of them. In the U.S., we call them HCM Centers of Excellence. That careful genetic history and testing should be performed. That every patient should have a risk assessment of sudden cardiac death. That children should be assessed differently in terms of their sudden cardiac death risk. We'll talk more about cardiac myosin inhibitors, but they should be used in the appropriate patient. We'll talk about the indications. That SRT, or septal reduction therapy, either myectomy or alcohol septal ablation, should be performed at centers that are dedicated to doing these procedures and referred to those centers. That anticoagulation for atrial fibrillation is essential, and that's irrespective of CHADS 2 VAS score. So every patient with HCM who has paroxysmal AFib should be on anticoagulation of some sort. That patients who don't have a outflow gradient at rest should, or with provocation with Valsalva maneuver, should undergo exercise treadmill test to provoke latent obstruction. And lastly, a new concept that exercise in HCM, at least recreational exercise, is beneficial. So what changed between 2020 and 2024 when the new guidelines came out? So first of all, there was a recommendation that extended ambulatory monitoring for those deemed at high risk of atrial fibrillation was recommended. And this was revised from the prior guidelines suggested that there were specific risk factors that should be used, but basically in the new guidelines said anyone that's at increased risk, which is almost every patient with HCM in a sense. For sudden cardiac death risk, in patients with more than one risk factor, that the discussion of the estimated 5-year sudden cardiac death risk and mortality is useful with shared decision-making for decisions about ICDs, and that's for all patients. It was revised from those over 16 years of age. Number 3, for patients with persistent symptoms from LV outflow tract obstruction, despite first-line therapy, and we'll talk about first-line therapy in a moment, adding either cardiac myosin inhibition, specifically mavacamten, is the only approved therapy right now, or disopyramide, which is a drug I personally don't use anymore, or septal reduction therapy is recommended. So the addition was CMI, cardiac myosin inhibition. For patients under 45 years of age with non-obstructive HCM, due to pathogenic sarcomeric variant and a mild phenotype, valsartan may slow adverse cardiac remodeling. That's based on one modest-sized study. In patients with persistent LV ejection fraction less than 50% on CMIs, the CMIs should be stopped. And the new recommendations about exercise, and I'll go into more detail about this, were that vigorous recreational activities are reasonable after annual evaluation and shared decision-making, that competitive athletics may be considered again after annual exam and shared decision-making, and that restriction from exercise is not indicated. And that restriction dates back 3 decades. We generated a generation of HCM patients who were couch potatoes and obese because they didn't exercise, and that led to worsening of their symptoms and in some cases obstruction. Another part of the guidelines was echo screening of asymptomatic family members. So children from genotype positive patients and their families with early onset disease should need to be screened every 1 to 2 years. All other children with a positive family history, but neither genotype positive nor early onset disease, they can be screened every 2 to 3 years with echo. And adults should be screened, adults of first degree family members should be screened every 3 to 5 years for the development of the phenotype of HCM. So this is the approach to patients with suspected HCM or a family history of HCM. If they're phenotype positive, they should undergo a complete baseline evaluation with sudden cardiac death risk assessment. We'll talk about those risk factors in a moment. Stress testing if symptomatic, if LV outflow tract obstruction is suspected but unconfirmed, or to determine baseline functional capacity. So that's the baseline evaluation. And then every 1 to 2 years, without any change in symptoms, they should have serial evaluation for clinical status, sudden cardiac death risk, atrial fibrillation risk, or any change in symptoms with clinical assessment and an echo, again, an echo every 1 to 2 years, as well as ambulatory ECG monitoring for both atrial fibrillation and sustained ventricular arrhythmias. A 2B recommendation was a repeat CMR for sudden cardiac death risk assessment every 3 to 5 years in a patient without an ICD to look for progression of scar, and we'll talk more about the use of scar to assess risk of sudden cardiac death, or to evaluate for morphologic change. I will say there isn't a lot of data in the literature about serial CMR. There are 2 or 3 small studies showing progression of scar, late gadolinium enhancement, mostly in patients who have scar at baseline and more hypertrophy than patients with less hypertrophy. In adults that are asymptomatic, 2B recommendation every 2 to 3 years was to do treadmill exercise or cardiopulmonary exercise testing, also called CPET for short, for assessment of functional status. Again, that was not a strong recommendation. 2B means certainly could do that. But in children or symptomatic adults, exercise testing is recommended, especially if there's a gradient less than 50, to see if the gradient is provoked to more than 50 with exercise. And CPET is recommended if the patient is being considered for advanced heart failure therapies. So let's turn to the pharmacological management of symptomatic obstructive HCM. So the left side of the slide are the class 1 recommendations. So the green is class 1, meaning every patient should have this done. And then the letters are the level of evidence, A being the strongest level of evidence, B being intermediate, and C being low level of evidence. You see most of the recommendations are based on B and C levels of evidence. So the first is that in patients with symptomatic obstructive HCM due to LV outflow tract obstruction, non-vasodilating beta blockers are recommended. Now, we'll see if that changes in the next set of guidelines when I mention one recent study, the MAPLE HCM study that was just published and showed that aficamten was superior to beta blockers for treatment of symptomatic LV outflow tract obstruction. So these guidelines now are a year old. The next set of guidelines that for first-line therapy may change. We'll have to see. Another recommendation that in patients with obstructive HCM and symptoms, when beta blockers don't work, that substitution with non-dihydropyridine calcium channel blockers is recommended, so either verapamil or diltiazem. Third, in those who either a beta blocker or calcium channel blocker do not treat the symptoms appropriately, adding cardiac myosin inhibitor, again mavacamten, or disopyramide. I will say in our practice we hardly ever use disopyramide. It's hard to get. It's from pharmacies. It has a lot of anticholinergic side effects, and it tends to have run its course after a year or two and stop working as well as it did when initially started. So I used disopyramide prior to the advent of the availability of CMIs, and I haven't prescribed it in about 4 years. I don't know, Matt, if you don't use it. Yeah, so almost never. It's still in the guidelines, but it's not used. And then septal reduction therapy as another option for patients, and you may decide between mavacamten and septal reduction therapy based on patients' age and comorbidities as to whether they are a better candidate for one or the other. For patients with, I'll skip that one, it's less important. In terms of the 2B suggestions from the guidelines, those with evidence of volume overload and high LV filling pressures, low-dose diuretics may be considered, and that patients with hypertension who are on vasodilators, those should, it's reasonable to stop those, and often that's the first thing you do with a new patient with LV outflow tract obstruction, because that may relieve obstruction in a subset of those patients. And that lastly, class 3, in patients with very high gradients as well as children, verapamil is potentially harmful. So this repeats what I just said in graphical form, that we start with right now, the present guidelines suggest beta blocker, verapamil or diltiazem, and if symptoms persist, I would say either a myosin inhibitor or septal reduction therapy, again, depending on a patient's age and comorbidities. Disopyramide, generally, we don't use anymore. Turning to non-obstructive HCM, there really aren't any good proven therapies for non-obstructive HCM. As many of you may be aware, the Odyssey study was just presented at ESC and published in the New England Journal, and mavacamten did not meet its primary endpoint in non-obstructive HCM, although it was quite close, and it may have been some issues with study design that precluded its positivity. But it appears at least some patients respond with non-obstructive HCM respond well to CMIs, but at this point we don't know who those patients are in terms of subset analysis. So there's an ongoing study of aficamten in non-obstructive HCM, Acacia, which will be resulted in 2026, so we'll know more about the role of CMIs in non-obstructive HCM. But right now, the only class 1 recommendation is those patients with preserved EF and exertional angiodyspnea consider beta blockers or calcium channel blockers, although the level of evidence for efficacy in this situation is really low. So they're, in my mind, generally not particularly helpful. 2A recommendations, it's reasonable to add oral diuretics with persistent dyspnea in these patients, low dose. Another 2B suggestion is that ACE inhibitors, ARBs, are probably not recommended. And then on the right side of the slide, in those with apical HCM with severe dyspnea or angina despite medical therapy, there are a few centers that perform apical myectomy, but really not that many centers. Only 2 centers in the U.S. that I know do this on a regular basis. And then in asymptomatic patients, there really is no role for therapy in this disorder. And again, this small study that showed valsartan may be beneficial in those younger patients with a pathogenic sarcomere mutation. So in terms of sudden cardiac death, an ICD is clearly recommended in those with a prior event. So for secondary prevention, those with sudden cardiac death, VF or sustained VT. In those without a prior event, the major risk factors in the U.S. guidelines are family history of sudden cardiac death, massive LVH defined as any wall greater than 30 millimeters, unexplained syncope, apical aneurysm, which is high risk associated with non-sustained VT and sudden death, and end-stage HCM defined as an EF less than 50%. Those are all 2A recommendations for an ICD, meaning an ICD is reasonable, and again, the patient, it should be discussed with the patient with shared decision making. Other potential risk factors are non-sustained VT, and that means a lot of non-sustained VT, several long runs on monitor, not short runs, not few runs. And in adults, that's a 2B indication for an ICD, and in children, 2A. So a non-sustained VT is more worrisome in children. And then lastly, extensive LGE on CMR, presently considered about 15% of LV mass, is a 2B consideration for an ICD. That amount may decline in future guidelines as there's more and more data that suggests that 10% of LV mass may be a better cutoff. A comparison between AHA and ACC guidelines. The guidelines I just presented to you, this was based on Marty Marin's paper in JAMA Cardiology, is highly sensitive, 95%, but less specific, 78% for predicting sudden cardiac death. The European guidelines, which do not use CMR criteria, are and use left atrial size and LVOT gradient in a calculator, are significantly less sensitive than the U.S. guidelines, but more specific at 92%. And that's been borne out in this paper from the SHARE registry by Carolyn Ho and European Heart Journal in 2021. Red is the U.S., blue is Europe, showing the use of ICD in this registry of several thousand patients. You can see by 10 years, a third of patients in the U.S. have an ICD, only a fifth of the patients in Europe. And if you look at sudden cardiac deaths, there's no difference in outcome. So one could argue that we're overusing ICDs in the U.S. And that's borne out by the higher sensitivity but lower specificity. And lastly, exercise. Exercise based on the LIVE HCM study, which was a registry study in HCM, NIH funded, that mild to moderate intensity recreational exercise is beneficial. Vigorous recreational activities are reasonable, so yellow. And in selected patients, they may be allowed to perform competitive sports, which is a change from prior recommendations, but after annual physicals and a careful shared decision making. And this chart basically repeats what I just said, that with shared decision making and an annual physical, vigorous or competitive athletics can be considered. So the real changes from the 2020 guidelines are twofold. One is that now cardiac myosin inhibitors are a class 1 indication for symptomatic LV outflow tract obstruction if first-line therapies have failed, beta blocker or calcium channel blocker. Again, future guidelines, they may become first line. Secondly, that now exercise recommendations have been liberalized, and HCM patients should be encouraged to at least do recreational activities and may be allowed to do vigorous and competitive athletics. And with that, I'll end, and thank you for your attention.